Good morning, everybody, or good afternoon, or good evening, wherever you are in the world. Welcome to our Virtual CDC Day 2020. My name is Joanne Williams, and I am the Assistant Director for Student Engagement at the Rollins School of Public Health. Since 2007, the Rollins School of Public Health has partnered with the CDC to host our Virtual CDC Day as part of new student orientation. And this year, while it's normally open for incoming students, it's open to all. Each year, our team selects a theme that relates to a relevant public health issue or topic. The purpose of this year's theme is to explore racism and the coronavirus pandemic as public health issues and understand how they may intersect or overlap with one another right here in Atlanta, the birthplace of the civil rights movement. You'll be hearing from our alumni and our faculty who will be working within these intersections. Before we begin our program, I'd like to introduce a special guest and our sponsor for this event, Dr. Eric Tebsner, the Director of the Epidemiological Workforce Branch and the Epidemiological Intelligence Service, who will offer a welcome on behalf of CDC. Thank you so much.
Thank you. It's a great pleasure to be able to welcome you here today to CDC on behalf of CDC leadership. The partnership with Emory University and the Rollins School of Public Health is extremely valuable to CDC, as is, I believe, also to Emory University. I'm an alum, and as a student, I know I benefited tremendously from the partnership between CDC and Emory University. We're very fortunate that many of the faculty are former CDC employees or current CDC employees, and they're able to share with you the wealth of their experience. We're also fortunate that many of the faculty are engaged in many of the public health activities with CDC that we do jointly together. And most relevant and important for you is we're so fortunate that we have programs like the Rollins Earn and Learn program, where you have the opportunity to work at CDC while you're students at the Rollins School of Public Health. It's really, I don't know how to describe how it is welcoming you to an empty room here today. Normally we'd have this full of all of you here to really orient you and give you a sense of being at CDC. I think back to when I was a student, and I don't know if Dean Curran remembers this, but when I started the Rollins School of Public Health in 1996, there was a lot of promotion around a new documentary that came out at that time called The Coming Plague, where public health experts from around the world were warning us that we need to be prepared for the next big pandemic. And here we are now in 2020, experiencing that pandemic that so many people warned us about. And I think that there's no more critical or important time to be a student in public health than right now. I think there is a great possibility we may see unprecedented investment in public health, possibly during the time that you are students and when you're graduating, and you are greatly needed for the rapidly expanding public health workforce that will be needed as we continue to deal with this pandemic and prepare for future pandemics and public health disasters. So it really is an extraordinary time to be coming to the Rollins School of Public Health, and I really encourage all of you to embrace this opportunity. I know that when I showed up as a student, I really truly didn't understand what public health was, and it was a dramatic experience for me that shaped my life in many ways that I could never have predicted. And I'm really thankful that the Rollins School of Public Health is taking the leadership to addressing racism as a public health issue. I think jointly with the pandemic and with the Black Lives Matters movement, it has now become to the awareness of many more people in America that racism truly is a public health issue, and also just a broader understanding of what public health is. If you are coming in as a student to the Behavioral Science and Health Education Department like I was, this will not be anything new to you. We've been talking about issues like social determinants of health for many years. And now it's great to see that this and many other issues like that our social determinants and racism are in the forefront of our minds and are being addressed. And so it's great to see the school taking leadership on this issue. And again, I encourage and welcome you to embrace all the challenges you may be facing, both working with CDC, and my last piece of advice for all of you is the partnership with CDC is great, but public health is really at the state and local level. And perhaps the best thing that I did while I was a student was working at Grady Hospital and with the local health department. And so I really encourage all of you to look for a variety of opportunities, both at the federal level, working with CDC, but remembering that public health is local. And so I encourage all of you to gain experience at the state and local health departments with the Grady Health System and other local entities here in Atlanta to truly enrich your experience. So with that, I just want to say thank you very much for the continued partnership with Emory University and Rollins School of Public Health. We're great to host you here today. And again, I wanted to welcome you on behalf of CDC leadership. Thank you very much.
Thank you so much, Dr. Pevsner. Now I'd like to introduce Dr. James Curran, who graduated from the University of Notre Dame, received his MD from the University of Michigan and his MPH in a university called Harvard. In 1981, Jim Curran was tapped to lead a CDC task force charged with determining what was behind the first cases of what we now know as AIDS. A pioneer in the HIV/AIDS prevention, Dr. Curran led the nation's efforts in the battle against HIV and AIDS for 15 years. And while at CDC, he attained the rank of Assistant Surgeon General. And now we have the pleasure of having him serve as the Dean of the Rollins School of Public Health. Please welcome Dr. James Curran.
So thank you, Joanne, and welcome to the incoming and returning students. It's especially gratifying to see Dr. Pevsner and Dr. Zeter here, two of our very distinguished alumni. And it goes to show when we say, always be nice to your students, because someday you may be working for them, that could easily be true with people like Dr. Pevsner and Dr. Zeter. So thank you for what you do. This really takes me back coming to CDC, because this is how I got my start in public health many decades ago. I said, well, you know, I think I'll try public health for a couple of years and see if I like it. And then I'll go into clinical medicine and be, like my parents thought I should be, a practicing doctor in their hometown. But I found public health so compelling and so interesting that I can't seem to stop. It's just a wonderful place to be. And CDC is a wonderful place to start your career and to start thinking about your career. So thanks to Eric and others for engaging us and employing so many students and alumni. When I think about public health now, in follow-up to what Eric Pevsner said, we're in the public health crisis of the century with COVID. There really has been nothing in the last 100 years that has really been like this in the United States, because it is spread by the respiratory route and affects everybody throughout the world, and it affects the economies and everything else in addition to its direct effect on human beings. There's never been anything like this. And that means the world is going to be different afterwards, in some good ways and some bad ways. But it's going to be different. All of the things that were happening before are going to be accelerated now in the future due to the public health crisis of the century. I can remember my late father telling me that the world was different after World War II. It was a war that encompassed the whole world, and the whole world would never be the same again. And I think that can be said of COVID as well, in a more modern way, that the world won't be the same again. I started public health at CDC during the end of the Vietnam War and the mid part of the civil rights crisis of the 1960s and 70s. And at the time, Martin Luther King was deeply engaged in the anti-Vietnam War process. And it is therefore no mystery to many of us that the COVID epidemic exposes the endemic racism in our society. Because like with other pandemics, the people who have suffered the most from discrimination and inequities suffer the most during the pandemic. It is not surprising that African Americans and Hispanics in the United States have higher infection and death rates due to COVID. But it must be not only explored, but something needs to be done about it. And ending racism is more than simply recognizing that it exists and recognizing our own complicity in it, but being committed to ending it. It's an active process, not simply an observational process. So that's why we think it's very appropriate during these COVID times and the Black Lives Matter times to think about these things in concert rather than simply separately. Now, public health is always political. That's good because it involves populations and involves changes in our society. And different populations, by definition, public health is about populations and it's about prevention. That means you have to move people along in groups to meet a common goal. So it's always political. During a pandemic, it should never be partisan. Public health should really almost never be partisan anyway, but certainly not during a pandemic. And one of the most discouraging things in our country now is the partisan nature of the approaches to COVID. Our leadership has not been good in the United States in COVID, nor in Georgia. We have not really done well, but there are reasons for optimism. And I'd say the reasons for optimism can be in three areas compared to, say, my initiation during the AIDS epidemic. The first is the progress of science. Since AIDS began, we not only have sequenced the human genome, but we're able to sequence a virus causing COVID within essentially days to weeks and circulate that sequence around the world to allow people to develop diagnostic tests, therapies, and vaccines. It took more than 2 or 3 years to even find the cause of AIDS. So the science is very well advanced, and there's reason to believe that there could be safe and effective vaccines. And certainly the approach of 165 different attempts that are ongoing now is encouraging that something may work. We're very proud at Emory in our School of Public Health, and especially in our medical school, to be at the forefront of that. And actually, we are not only developing drugs and working on vaccines, but at the forefront of testing both therapies and vaccines. Yesterday, I myself signed up to be in a vaccine trial. My wife said, "Aren't you a little old for a vaccine trial?" And I said, "No, I'm not too old for a vaccine trial." So I signed up for the COVID vaccine trial yesterday. So the science is part of it, but the science is still incomplete. There's many things we don't know about the duration of immunity. We don't know about the changes in the virus. We don't know how it's going to affect populations in the developing world. But there's reason for optimism. The other main reason for optimism is that the virus only lasts about 3 weeks. HIV lasts for a lifetime. So there are 40 million people who are infected with HIV, and they will be until they die, although therapies are much better. So it's hard to really end something when you have a lifetime infection. With the 3-week virus, if we could stop all of the infections today for 3 weeks, we would not have any more infections in the world. And that means that all of the people who are going to be hospitalized and die in October have yet to become infected. So it's not a given that COVID is going to do awful things for the rest of the year. And there's proof that it can be stopped and slowed down a lot. That proof occurs in South Korea, in China itself, and in New Zealand, and even in many countries in Europe, although there can be resurgences. New York State is the most remarkable example from my point of view because they had 800 deaths a day going down to 1. And when people say, well, Americans simply don't obey orders, anybody who's been to New York City would not find the most compliant, less crowded population you could find, but it's the most densely populated city in our country, and yet they can shut down COVID. So there's a lot of reason for optimism that this could happen if we had consistent leadership, a political will, and widespread compliance. The third reason for optimism, I think Dr. Pevsner mentioned, and this applies to all of you who are beginning your careers in public health, and that is no longer are people going to say, what is public health? Why are you doing that? They're going to find all the good things about public health and all the things that need strengthening, but people are going to say, we better do it right next time. We better strengthen those infrastructures. We better strengthen CDC and state and local health departments. We better get medicine and public health working more closely together. We've got to be able to stop having a society where we lay off 1 million healthcare workers because they can't do elective surgery but don't have anybody working in public health. That certainly isn't how China did it. They just said, well, if you can't do this now, you're going to go do that, and we're going to erase this. So I think there's going to be a reason to believe in our country that public health will be strengthened, and I wish I could be with you for another 40 or 50 years in your career. Thanks so much for joining us. Another reason for optimism is Emory's new president, Greg Fenves. Greg comes to us with a strong background in science and academic leadership. His last 12 years at the University of Texas commenced with being Dean of the College of Engineering, a civil engineer who specializes in the resistance to earthquakes. And in a sense, that's a public health problem, figuring out how to save lives during earthquakes. And then he was provost and finally the distinguished president at the University of Texas, where, among other things, he had to watch them begin the COVID response up until August. But in addition, when he first became president, he was a staunch defender of civil rights by defending the university's actions to affirmatively help minority students. And he was successful in that. So he fits the themes very well as we do this, and we're really honored to have him here to welcome us. President Gregory Fenves.
All right, well, good morning, everybody. Dean Curran, you are a very hard act to follow. What an incredible summary of where we are now and the role of public health and the optimism that we face. I've only been at Emory 3 weeks, and I'm so glad to be here at the CDC. And I want to thank Dr. Pevsner for inviting us here, and he said it better than I could as a professional and a leader. What a time to be in public health. What a time to be a student at the Rollins School of Public Health. And what a time to be at Emory here at the epicenter, and I'm an earthquake guy, so I can use the word epicenter, at the epicenter of this pandemic, where we have smart people, dedicated faculty, really motivated students to address the problem of the twin pandemic that we're facing that are intertwined and is the subject of the theme today, COVID and racism. So let me say a few words about Emory. I've only been here 3 weeks, and I've wanted to focus on what we are doing as a university. So I've actually spent quite a bit of time with the Rollins School of Public Health. In fact, I probably shouldn't say this, but I think more time with the Rollins School of Public Health than any school at Emory University because of the time we're in. I met with the faculty at the faculty retreat. I joined with several of the students in the Crown program who are quickly pivoted in the spring in their study of public health to addressing the problem of COVID here in Atlanta. And it's just been an amazing story to see what they're doing. One of my first visits on my first official day as president was to visit with Dr. Rafi Ahmed and the vaccine center here at Emory. And I was optimistic after hearing from Dr. Ahmed about the work that's taking place here, both in therapies, but especially in vaccines, and the special work that's being done and moving into clinical trials. But here in Atlanta, the home of the civil rights movement, couldn't have a more important place to be addressing the issues of health, public health, and systematic racism and the intersections between these two. And just echoing what Dean Curran said, if you just look at the disparities and how this disease is affecting African Americans and Hispanics. It's happening here in Georgia. It was happening in Texas, where I came from. It's happening across the country. And there are systematic reasons that has happened. that have developed over a long period of time, and this is the time to be addressing that change. And the faculty and the students and the alumni that I've had the privilege to meet with and talk with are so dedicated to solving these problems both locally, across the country, and globally. And one of those is going to be our speaker in a few moments, and I'm such an honor to introduce the Rollins School of Public Health graduate who has done exactly that. Dr. Angelica Jeter is the first ever Chief Health Officer for the City of Atlanta. So we were chatting a few minutes ago. You never know in your lives and in your career what's going to happen when you make a decision. So Dr. Jeter started last July as the first public health officer for the City of Atlanta. And you didn't know what you'd be dealing with. None of us knew that. And we have the right people at the right place at the right time. She was appointed by Mayor Keisha Lance Bottoms to lead the development of public health strategies to combat the leading causes of illness and disability and to improve health disparities, to remove health disparities and assess the emerging health needs for how we have a healthier and more equitable Atlanta. She's a public health expert with experience at the federal, state, and local levels and currently leads the mayor's pandemic coordination team in response to COVID-19, tasked with ensuring the continuity of city operations and the public safety and public health. She's also directs the mayor's COVID-19 reopening phase guidelines and serves as a public health liaison to establish and enhance the protocols in the city of Atlanta, the guidelines, and the partnerships with local organizations and businesses. Dr. Jeter is committed to the health equity, and she uses collaborative approaches to research, policy development, community engagement, and emergency response. So it's, as I said, it's clear we have the right leader here in Atlanta for the times that we find ourselves in. And I would add to Dr. Dean Curran's 3 reasons of optimism, a 4th reason for optimism. Let me introduce her, Dr. Angelica Jeter.
Had I thought about it, I would have worn a cuter mask today, but clearly now that is a thing. I am so humbled by that introduction, and welcome, Dr. Fenves, to Emory University. Welcome to Atlanta. Thank you, Dean Curran, Dr. Jacob Areola, and Dr. Pinzer for just being here today. I was speaking with Dr. Jacob Areola. She rescued me in trying to find my way here. And I said to her, it's been exactly 10 years since I graduated from the Rollins School of Public Health. It's been 12 years since I moved to Atlanta. And 12 years since I moved to Atlanta. And I remember orientation. I remember being so nervous about meeting Dean Curran, meeting professors who are no longer with Rollins, but they were part of the reason why I wanted to do this work. And I remember walking through Dr. Jacob Areola's door and asking her to be my thesis chair. I knew I was interested in HIV. I was interested in addressing disparities in the South, and I was interested in finding a way to do more work around programs and interventions and focusing on young people, people who are my age who are being diagnosed. And so the Rollins School of Public Health is a place where I really got my feet wet in public health. I really got a chance to learn more about what it means to work in public health and design programs and interventions and connect with people. And so just thank you for the opportunity to be here. And I am so excited. And with that, I will get us started.
We also recently hired Dr. Angelica Jeter, Ferguson. Our city's first ever Chief Health Officer. She will work to reduce HIV infection rates, expand access to PrEP, and eradicate the stigma around these issues in Atlanta. Because the question that I've asked is, San Francisco can do it, then why can't we?
That's right.
So I love this video. And part of the reason why I love it, even with this graininess and one of my closest friends yelling my name in the background. I love it simply because it's a reminder of two key things. There was a time when we could gather together and celebrate and be able to be in the same space without fear. And it also reminds me that there was a plan. Before the pandemic hit, we had plans to address HIV and AIDS within the city of Atlanta, to enhance a lot of our local efforts in partnership with the local health departments. There were so many plans and partnerships that we were implementing, but with most stories for 2020, mine shifted with the words, but then the pandemic hit. And that changed every single thing that we planned as it relates to my role as Chief Health Officer through the city of Atlanta. And so for the presentation today, I'm going to discuss how we have led our response, the approach that we've used, and how we've had to focus on racism in the midst of another pandemic with an invisible enemy. So when we think about what's happening with the pandemic currently and what's happening in the state of Georgia, we rank first in new cases per 100,000. That's 213 cases compared to the national average of 114. The counties with the highest number of cases include Fulton, Gwinnett, and Cobb. And based on recent HHS and White House reports, there have been no substantial improvement to within the Atlanta metro area. And when we talk about Fulton County, 43% of COVID cases occurred in Atlanta. And I was telling President Fenves earlier, most people don't realize that the city of Atlanta does not lead our local health department. We have to collaborate with our local leaders at the county level and the state level in order to get more information as it relates to data, to learn more about those public health guidelines and initiatives. So anything that you see that's coming out of the city, we're primarily collaborating with Fulton County to get that information. And Fulton County represents a large portion of Atlanta as well. So when we talk about what's happening in Fulton County, most of that includes Atlanta. That data that we get from those local health departments also gives us a better understanding of what's happening as it relates to racial and ethnic disparities. And we know that Black men and women represent 41% and 83% of COVID-19 diagnoses and deaths in Atlanta. 41% and 83%. And these are numbers just from earlier this week. The numbers change every day, but consistently, this has been the average. So when we ask ourselves the question, why do Black residents account for, again, 41 and 83% of COVID-19 diagnoses and deaths in Atlanta? There's only one answer for me, and racism is that answer. The picture at the top is just from last weekend at Stone Mountain, where people were rallying regarding them wanting to have their voices heard, but we're faced with the reality that much of that has been marked with racism. The second picture is a photo from a Black Lives Matter march that happened downtown in Atlanta over the summer. And the very last photo is the message that we have been drumming for decades, that racism is a public health crisis. When we talk about racism, race, and public health, I honestly am so excited that the curriculum has shifted as it relates for Rollins School of Public Health. The required readings that focus on racism, cultural competency, and empathy. But I honestly believe that no student should leave Emory University and be able to say that they weren't taught about racism, they weren't taught about race, and they didn't know that racism is a public health crisis. Racism is a system of structuring opportunity. Racism is a public health crisis. Race is a social construct. And when it comes to COVID-19, race is not a risk factor. It is the systems that embody racism, that make people more vulnerable for COVID-19. There is a quote by Kamara Phyllis-Jones that has really stuck with me throughout my entire career. She talks about how racism unfairly disadvantages some and advantages others. But the last portion of that quote says that racism saps the strength of the whole society through the waste of human resources. And when we talk about racism and the fact that we have to spend a lot of our time lifting up the fact that racism is a public health crisis and convincing people that this is still an issue, that is time that's wasted that wasn't focused on the pandemic. That's time wasted that wasn't focused on other chronic illnesses and diseases that we needed to address. And so I totally agree, racism is a public health crisis and it saps the strength of the whole society through the waste of human resources. So when we paint the picture around racism and COVID-19, for the purposes of my presentation, I'm going to focus on structural racism in particular. But Dr. Kamara Phyllis-Jones places a lot of emphasis on structural racism, personally mediated racism, and internalized racism. And for students who are walking into the Rollins School of Public Health, it's essential for you to know these different categories and how, when you leave Rollins, you will have a responsibility to really understand the communities that you serve and the things that they're facing. So when we talk about structural racism, we're focusing on the differential access to services and opportunities. When it comes to COVID-19, we're talking about access to testing, care, information, and resources. For personally mediated racism, we're talking about discrimination that is based on negative assumptions. And then just the assumptions that people will make about a Black person when they're wearing a mask and walking into a store, as one example. Internalized racism is when someone would choose to accept or decides to accept those negative messages, and it enhances the level of fear as it relates to stigma, and it also feeds that lack of trust within the system. When we talk about structural racism, disparities, and our community's vulnerability for COVID-19, there are three key areas that I've consistently seen that's impacting vulnerability for COVID-19, especially when we talk about racial and ethnic disparities. That's economic stability, housing, and health. Consistently, we've seen disparities as it relates to unemployment at every educational level across the board. We know that our frontline and some of our essential workers have limited paid sick days and ability to work from home. When we talk about housing, we're talking about residents who are living in multi-generational households with limited resources, and those who are living in densely populated housing structures, making it very difficult to practice physical distancing. And then health, we are really thinking about those underlying health conditions, the status of our residents' health prior to COVID-19. We're also talking about those higher rates of chronic illnesses that disproportionately impact our community by race and ethnicity. So, getting to the work that we finally did through the City of Atlanta and the Office of Mayor Keisha Lance Bottoms, we used policy and public health initiatives to address structural racism and COVID-19 in Atlanta. Still focusing on those key areas, we put an emphasis on economic mobility, again on housing, and then on health. Regarding economic mobility, we were the only city in the entire state that received COVID relief funds. They did receive it at the county level. We were the only city that received COVID relief funds. So we established hazard pay for frontline employees, financial relief funds for residents, business grants and loans to enhance our economic mobility efforts. For housing, we established moratoriums for no residential evictions, filings, or terminations of water services due to non-payment. We also established rent relief funds for our residents, shelter options for persons experiencing homelessness. And then when it came to health, we just established free COVID-19 testing for our frontline employees to ensure that those who have been working since the very beginning, who have higher levels of exposure, potential for exposure and vulnerability, would quickly have access to testing and care. The City of Atlanta already had, for years, a wellness center. So they didn't have to go far for care, but we wanted to make sure they had quick access to testing. And last but certainly not least, for these three categories, we now have a $7.7 million partnership with the Fulton County Board of Health to expand COVID-19 testing and contact tracing with a special emphasis on communities with limited access to care. Just last week, we also made this announcement. We are enhancing our public health lens to expand a larger focus on racial and ethnic disparities within the city of Atlanta. As Chief Health Officer, I will be leading all of these efforts to develop a new racial and ethnic disparities COVID-19 report. We will be convening an advisory council of members of our community to inform that report. One thing that I want students to know, for any decision or efforts that you make, it should involve a community voice. It is important not to make a decision and skip out. It's important not to make a decision without the voices of the people that are going to be impacted by your decisions. And so we will convene an advisory council of community partners, establish a COVID-19 mass campaign that will promote messaging so people can understand that the disparities exist. And then we are planning a series of virtual town hall discussions concerning the effects of COVID-19. The very first one will be on World Mental Health Day, and the topic will be emotional wellness and women. And so we are so excited about this initiative because we are bringing things full circle as it relates to public health and lifting up some key factors that are happening within our community. With that being said, the work continues. COVID-19 is not over, even though some people want to pretend as if it is. And despite that all of these things are happening, this is our new normal. And in the midst of a pandemic and another global emergency, we are in the middle of the heightened awareness as it relates to racism in the Black Lives Matter movement. The death, the murder of George Floyd, Ahmaud Arbery, Breonna Taylor, and Rayshard Brooks, and so many others that aren't listed here, reignited the Black Lives Matter movement over the summer. And while we were outlining our pandemic efforts and implementing things as it relates to health, economic mobility, public health, and housing, we were also reevaluating what needed to be done as it relates to our commitment to the Black Lives Matter movement. And after the murder of Rayshard Brooks, Markeisha Lance Bottoms issued administrative orders related to transforming the Atlanta Police Department. The orders call for the adoption of reforms regarding APD's use of force policies and a comprehensive look at how we police in Atlanta. It's not enough for us to just call on racism. We have to put policies behind it. We have to put funding behind it. We have to be able to establish some essential partnerships and get rid of those pipelines that fuel discrimination within our community. And we have made a true commitment to doing just that. Everything that I've mentioned today are policies, programs, and initiatives that we are using to promote lasting change and navigate racism while we fight against our new invisible enemy. This is our work. This is our good trouble. And the work continues. And with that, I will leave you with some of the final words from our city's hero. Ordinary people with extraordinary vision can redeem the soul of America by getting in what I call good trouble, necessary trouble. I urge you to answer the highest call of your heart and stand up for what you truly believe. New class of the Rollins School of Public Health, those who are pursuing their passion, their purpose, and interest at Emory University, now it is your turn to let freedom ring. and to continue on with the work that we're doing in the field of public health and through every department at Emory University. Thank you.
Wonderful. Thank you so much. What a great keynote with a lot of wonderful lessons and some updates on what's happening here in the city of Atlanta. We really appreciate all of your time in joining us today. We've collected a couple of questions from incoming students, returning students, and some faculty and staff. So we might not be able to get to all of your questions today. But I encourage you, as you're asking your questions or you have questions for Dr. Jeter, feel free to drop them in the Q&A box, and I'll receive them via text right up here. Thank you so much. So Dr. Jeter, the first question that we have from an incoming student is if you could talk about the path that you took to get to where you are today.
So people ask me this question, and I can honestly say that the path that I planned for my life is the complete opposite of what has happened. So as I mentioned before, my work began, when I really think about it, it began with community-based organizations. I was working, I'm originally from Jackson, Mississippi. I've been doing work within the community, and all of it is focused on HIV and AIDS. So I've been doing HIV research for almost 20 years at this point. I wanted to know what was happening in our community, so I worked with the local organization. And then I was at the local health department. If you really want to know what's happening in your community, work with the local health department to find out. And from there, my mentor, Dr. Leandro Mina, said, you need to go to Emory. I didn't know what Emory was. I didn't know what public health was, and I feel like most people kind of trip and fall into public health in some capacity. But I applied to two schools, Emory University and Tulane. Tulane turned me down. But the day after I got the rejection letter from Tulane, I got the FedEx package that had the letter. And, you know, before I even opened it, I was like, I got in, I can't believe it. And then I was off to Atlanta. And my public health career in Atlanta began at the Centers for Disease Control. As a graduate student, I was working here in HIV, learning about program evaluation. I then graduated, became a consultant for CDC. That was 10 years ago, back in May. And then after I got my doctorate, I earned my doctorate in public health at University of Kentucky, and I was still being taught by Emory graduates. And eventually, I completed my postdoctoral training at Morehouse School of Medicine under the mentorship of Dr. David Satcher, who was the only Black man to ever be the director of the CDC and first Black man to be U.S. Surgeon General. When I came back to CDC after that for 3 years, I did not know what I was going to do. The position that I currently have did not exist. And I was trying to decide if I was going to stay at CDC and continue my work or go back and do more work with community-based organizations. And then I got a call from the office of Mayor Keisha Lance Bottoms. They had seen some publications that I had been doing out of CDC, and all of it was focused on disparities, and now we are here today. And so the path that I took was really like, I'm going to work at CDC, I'm going to do research, I want to be in BC, I want to, design interventions, and only a portion of that happened. And everything that happened with my role as Chief Health Officer, it wasn't planned because the position never existed. So I would say pursue the passion that you have, go after and pursue the positions that you want, and go as hard as you can. But I don't think that people should focus on the plan that I took. They should find their own. That's important.
That's awesome, and that's great advice for your students, and we are so glad that you joined us at the Rollins School of Public Health, for sure. Our second question is, as Chief Health Officer, how do you navigate implementing health and safety practices despite some of the political challenges?
thankfully, oh, how do I say this and not get in trouble? Thankfully, I work for someone who understands that COVID is still a problem. And thankfully, I don't have to navigate too much of the politics. Mayor Keisha Lance Bottoms is very good at handling that. But what I will say is that she is someone who is extremely intelligent. She has taken the time to understand the public health crisis. She knows the numbers. She understands the science. She reads about it every single day. And because of that, because she got it, and she is not focused as much on the politics, but really helping residents, that makes it a whole lot easier for me to do my job.
That's amazing. Thank you so much. The third question that we have that was submitted by another incoming student is, what efforts has the City of Atlanta taken to mitigate the disproportionate impact of COVID-19 on the Black community?
So part of that is what we just discussed during my presentation. So really focusing on economic mobility, housing, and health. And then now the new initiative as it relates to racial and ethnic disparities to highlight the report, the messaging, the mass campaign, developing certain resources, expanding COVID-19 testing, contact tracing, local partnerships. So there are multiple things that we've done in thinking about it on both sides. Being able to develop policies that expand resources, all while enhancing the public health lens and moving that forward as well. So we are doing multiple things to help residents and business owners and promote messages so people can understand that disparities exist. I don't think a lot of us get that because we do this work, but a lot of people don't understand that the disparities are happening. So I think that's important as well, and that's part of what we've been doing.
Great, that's really good to hear. And how can we move beyond simply acknowledging racism in public health to talk about why it exists and how we can combat it as public health professionals in our everyday work?
As it is important to name and call out racism, but again, it's also important after we take that first step is to put policy, legislation behind it to enforce what it is that we say we believe. It's important for us to create the partnerships that we need to create to increase access for those who are disproportionately impacted or affected by racism. That means that we're putting money behind what we say. It's important for us to, one thing that I do know, and I've been thinking about the changes that have been happening with the required readings at RSPH. That takes a lot of the pressure off those who are disproportionately impacted on having to educate those who aren't knowledgeable. And so it's important for us to educate ourselves about that topic so that when we operate in our everyday lives, we aren't adding to the problem. So education and awareness, policy, funding, legislation, and then also naming it as well.
Awesome, thank you. And, you provided some advice for incoming students, but our students are also wondering, what recommendations do you have for those who wish to hold the same position as you in the future as Chief Health Officer of a major city?
Be careful what you ask for. I would honestly say that every single experience that I had enhances my work as Chief Health Officer. So working at the local level to learn what was going on in the community that I lived in. Working at the federal levels to understand what the role is of the federal government and what CDC does and why it's so important as it relates to pandemics and public health. But I would say, and that's my experience, isn't a requirement. What it takes is a sense of passion, heart, being highly skilled as it relates to public health knowledge, the very thing that you will gain from Rollins School of Public Health at Emory University. It also takes a whole lot of patience. And then I would say making the decision as to whether or not working at the local level is for you. And when I decided to be Chief Health Officer, I had no idea what I was getting into, but I have no regrets. So I would say try to get as much experience as you can at the local and state levels, as much as you possibly can. And then think about comprehensively what it is that you would want to accomplish if you had a role like mine. Because one piece of consistent advice that I received is that you can't do it all. Choose one or two things that you want to accomplish and pursue that to no end.
Wonderful. And for you, what were those 1 to 2 things that you wanted to accomplish?
Like I said, there were so many plans. I wanted to enhance our relationship with our local health departments. I wanted to expand the conversation around PrEP in women. We were outlining some mental health initiatives, again, for women and their families. And then I wanted to look at healthy eating and active living. So I had 4 things. 2 of them were being rolled out, HIV and mental health. But then again, the pandemic hit and everything changed. Hopefully, within the next year, we'll be able to get back to that.
Awesome. Thank you. And so, for incoming students, you as a Rollins alumna have encountered a lot of different experiences while you were a student here. So can you talk about your time when you were here at the Rollins School of Public Health as a student?
I can honestly say so I was president of the Association of Black Public Health Students.
Yes, awesome.
And I don't remember how I became president. I don't remember how that happened, but eventually I did. And we did a lot of really good work, bringing in community partners, connecting with people outside of Rollins and teaching them more about that. So that was a wonderful experience. I remember walking the halls of Rollins, and Dean Curran would be just walking through the building. And when I learned about all of the work that he was doing, I just like, how is this legend walking through the building, and how do I get a chance to sit down and talk to him? I don't remember all of the presentations. I remember a lot of what I learned, but the most memorable things for me was the opportunity to sit with the professors that I admired the most, and the kindness of Dean Curran, and the amazing work of my thesis chair, and being able to sit with a couple of professors who are no longer in Rollins to learn about what they were doing about HIV and AIDS. And so I came from Mississippi, and I had never been introduced to people from around the world because I'd never really traveled. And Rollins introduced me to people from almost every part of the world. It was very different. It was all new. And I just remember the connections that I made. I learned a lot, and I took that with me, but the connections that I made and the conversations that I had with my professors, that's what stuck with me for the rest of my career.
That's amazing. Well, thank you so much again for joining us. Give Dr. Jeter a round of applause.
Thank you.
Thank you, everybody, and that will lead us into our break or our intermission. And so we will take a break right here, and we will reconvene at 11:10 a.m. Eastern Time for the faculty and alumni panel that will be led by Dr. Kim Jacob Ariola. Thank you very much. All right, excellent. We will go ahead and get started again. Thank you so much for sticking around, and welcome back to our virtual CDC Day. We will get started with our faculty and alumni panel presentation, but first I'd like to introduce our moderator. Dr. Kimberly Jacob Ariola is the Charles Howard Candler Professor in the Department of Behavioral, Social, and Health Education Sciences in the Rollins School of Public Health at Emory University. Aside from being a faculty member, she serves as the Executive Associate Dean for Academic Affairs for the Rollins School of Public Health. In this role, she serves to steward the academic mission of the school. Her research career is dedicated to improving the health of marginalized populations and communities of color. And thus, for the past 20 years, her work has focused on social and behavioral factors that impact the health of African Americans. So please welcome Dr. Kimberly Jacob Ariola.
You can't see me smiling behind this mask. That was such a kind introduction, Joanne. Thank you very much. And welcome to the Rollins School of Public Health, to our incoming students. I would like to invite each of our panelists to introduce themselves and provide a brief description of their work as it relates to diversity and inclusion efforts and/or COVID-19. Perhaps we could start with Mr. McCurdy. Welcome and thank you for coming.
Yeah, sure. Hi, everyone. Matthew McCurdy. I'd like to say welcome to Rollins, to the incoming class. I can assure you that the time at Rollins will definitely change your life. I graduated from the BC program in 2016. From there, I joined federal government as a presidential management fellow at the Department of Health and Human Services, where I work as a senior advisor for strategic management. I'm also co-founder of the nonprofit Black Health. Black Health is an Atlanta-based nonprofit that educates people on racism and health of Black people and develops interventions that help mitigate the impact of racism on the health of Black people. We have two main areas of work. Firstly, we work with organizations and schools to support health leaders in developing anti-racism and health competencies. And secondly, we work with local and digital communities to empower Black people to make more informed health decisions. So really working at the intersection of racism, race, and health, largely, but more focused on COVID lately because it is a pandemic.
Thank you so much. Ms. Mukongo.
Yes. Hello, everybody. Welcome to, I guess, your first day of school. I'm not sure. But I am a graduate of the executive MPH, and my area of focus was prevention science. I am the founder and president of Amani Women's Center, a community-based organization in Clarkston, Georgia. For those who don't know, Clarkston is the most diverse square mile in the United States. And over the years, hundreds of refugees have been resettled in Clarkston. So it's a square mile with over 60 languages that are spoken there. And with diversity comes numerous challenges. And so in realizing what's going on right now with COVID, the Amani Women's Center has doubled our efforts and pivoted our services to respond to COVID-19. And we've been very intentional in informing, educating, and empowering the refugee community since March of this year. Our community is in a more vulnerable position of contracting COVID-19. The most obvious challenge is language. And so what we have been doing is providing information to the refugee community from credible sources like the CDC and the Georgia Department of Public Health, and making sure that the community is getting the right information. Secondly, we've been making sure that the information is in languages that they can understand, which is very important. A lot of beautiful flyers are passed around in not very few languages. And so, the refugee community gets these flyers and they don't know really what the flyers are saying. Also realizing that the community receives better from trusted voices like our community ambassadors. So we have been having our community ambassadors be the ones to reach out to the community and educate the community on COVID and 19 and what resources are out there. And also to make sure that the information is digestible, meaning that, there are language challenges and there's literacy challenges. So figuring out how to work around that. And we have done that by creating PSAs in video formats in the various main languages that are spoken in Clarkston, and getting that information to the refugee community through social media platforms that they frequent. And also we have a powerful sewing program that graduated refugee women in the first week of March, I think, right before all this happened. And so the women who acquired these skills have been using the skills to make face or facial masks for following Emory healthcare guidelines. And we've been able to outfit frontline healthcare workers, and especially the refugee community. Most of them work in poultry farms, and poultry farms are hotspots for COVID-19. And so we've been able to give those face masks to the community, and most of them would receive disposable face masks and end up reusing those. And so we feel like this is a very much needed preventive measure that they can actually reuse and wash and so forth. So we're doing a lot around COVID. I don't want to take too much time, but yes, that's what we're doing.
Thank you so much. I was just messaging Joanne to see if we could figure out how to get some of those masks. But thank you so much. Dr. Sullivan.
Good morning, and welcome to all of you. Welcome to Rollins. My name is Patrick Sullivan. I'm a sort of Emory alum and faculty, I guess. I did my undergrad at Emory and started my public health career in the Epidemic Intelligence Service at CDC, and worked a total of 12 years at CDC, mostly in public health surveillance programs. And I'm starting my 13th year at Emory. My interests are infectious disease, epi, and pre-COVID, my fare was almost 100% HIV prevention and sexual and gender minority health, working with mHealth tools and data visualization. But I find that many of us in ID epi and in other areas of epi and program are now called, as my colleagues mentioned, into COVID. So I'll just mention a bit about how those activities have pivoted during the time of COVID. So first, I think that I sort of feel like a lot of epidemiologists I know have said some version of this is what we train for. And so however we train and whatever we do, there's such an opportunity now to try and shed light both on the epidemic, but particularly on the health inequities that are occurring within the epidemic. And so I've been working with colleagues on the data side to try and analyze big chunks of data to understand the patterns of who's impacted with COVID diagnoses and deaths and the racial and ethnic disparities. And so I work with Greg Millett from AMFAR to use an ecological analysis, just looking at the characteristics of within counties and which counties are more impacted. And Greg's analysis found that counties with higher proportions of Black residents had both higher rates of COVID-19 diagnoses and death. And this was especially true in rural and small metro areas. And so when you start to dig down in these analyses and ask why, unfortunately, the themes are ones that we know. The excess cases and deaths were related to lack of health insurance, to high occupancy, people living with more than one person per room, to employment and being employed, which is sort of a different kind of association. But in this epidemic, it's especially important to remember that Black and brown people are less likely to have jobs that are amenable to telecommuting. So working might mean being in contact with more people and having a harder time social distancing. So that's that's sort of for African Americans and other Black Americans. Carlos Rodriguez Diaz from George Washington asked a similar question about how cases were associated with counties relative to Hispanic Latinx populations, and found that cases were higher in counties with more Hispanic Latinx residents, especially in the Northeast and the Midwest. And what he found was that driving these associations are more monolingual Spanish populations and less social distancing. And deaths among people in those predominantly Hispanic counties were related to higher household occupancy, worse air quality, and employment. So these themes that it's really, that race is really a marker for a variety of inequities and structural inequities that influence a lot of health outcomes, really speak back to sort of our epidemiology and public health practice as cutting across a lot of areas of health. And I would just say we're trying to respond to that by figuring out better ways to engage Black and Hispanic communities in COVID-related programs and research. So that might be trying to understand what the barriers are to having people in different communities join research or testing programs. And then I feel really honored to have worked with a colleague, Jody Guest, and a team of Emory public health students called the Outbreak Response team, who have been standing up testing opportunities in the very communities that research identifies as vulnerable. So going to places where there may be more monolingual Spanish speakers, or in more rural or smaller metro areas in Georgia, and offering testing. And it's been a privilege to work with that group. And what we're able to do is use those testing events to also try and advance research to understand new, innovative, and easier ways to offer COVID testing.
Thank you so much, Dr. Sullivan. And last but certainly not least is my colleague in BSHEs, Dr. Brianna Woods-Jager.
Hi, welcome everyone to Emory. We're so excited to have you all here and in the School of Public Health. My name is Brianna Woods-Jager, and I'm an assistant professor in behavioral, social, and health education sciences. And in terms of my research overall, my research really aims to partner with communities to eliminate health disparities associated with chronic stress and trauma. And so I take a community engaged approach to my research to really examine what the social and structural factors are that influence the disproportionate burden of trauma and adversity in communities of color, and then to develop, implement, and evaluate interventions to address the inequities associated with this disproportionate burden. And so the community engaged approach is critical to my work and really involves bringing community voices to the table at the beginning to identify and develop strategies to address the community concerns, building on community strengths. So really having an asset-based framework in doing this work. Two of my current projects are focused on youth violence prevention and mental health promotion, with an emphasis on mitigating racism across sectors, in particular the education, law enforcement, and mental health care sectors. And these were priorities identified by our youth partners and through formative work we've been doing for the past 3 years through focus groups, interviews, and community level surveys to really understand not only what are the issues, but what are the priorities of the community in terms of how they want to address these issues. So I'm really honored to work with amazing community partners. And as COVID-19, as the pandemic has unfolded, these partners are on the front lines. And so they've had to really adjust real time to really have their impact focus more on the pandemic. And with that, we've adjusted in our work as well to really look at how these disproportionate burdens of stress and trauma that already existed in communities of color are now being exacerbated further by COVID, particularly when we look at the brunt of the health and economic tolls of the pandemic. And in particular, we're focused on mental health among youth of color, because that's an area that while some people are starting to recognize, we really need to be focused on this, it's not receiving as much attention. And we're concerned about this because what we've heard from our work prior, particularly from Black youth, is that their mental health is ignored, and that's often met with more punitive responses rather than with supports, either access to care, or even just people that are really looking at the behaviors and their experiences with more of a therapeutic support approach. And so we're really trying to better understand how is the pandemic impacting youth of color in terms of their mental health, and what are the priorities, really hearing from youth and families that they want to see in terms of how we can address those mental health impacts. And I'm so honored to be working with amazing community partners. Really, I'm fortunate to work in many communities. So I have partners in Kansas City that I've been working with for the past 5 years on these issues and building partnerships. I've been at Emory for 2 years and have been really fortunate to be working with the Department of Juvenile Justice, with an amazing community partner called Sur Familia, who works with the Latinx community in Georgia. And we're building partnerships with school-based health centers and community-based organizations like the Boys and Girls Club, who have just joined our Community Action Board, which we're really excited about. And so I would just say the work is, there's a lot of work to do, but the exciting piece is that people are coming together and are really looking for partnership opportunities. I've just been overwhelmed by how open people are to working together and to really addressing mental health in particular, because often this is an issue that sort of is, people are aware of it, but it's not as much on the forefront. So I'm feeling like people are starting to really recognize this more and address it, and really excited to partner with folks in this community engaged research.
Thank you so much, Dr. Woods-Jaeger. And again, welcome to all 4 panelists. Thank you to the many students who suggested questions in advance to our panelists. We do have a few questions just to start the conversation, but for those of you who are listening, of course, if you think of additional questions you would like to ask the panelists during the call, as Joanne mentioned in the chat, please use the Q&A feature to submit your questions. We may be unable to get to all of the questions during this particular event, but know that we'll certainly give it our best shot. I'd like to start with this question to any of the panelists. In your opinion, how should public health professionals prepare so that we can be effective in the workforce while being culturally sensitive?
I can go first. Okay.
Please, thank you.
Okay. I would encourage embracing the concept of cultural humility. And what this looks like is it pushes you to challenge your assumptions and judgments and prejudices that you may have, or preconceived notions that you may have about a community that you're working in. And it encourages experts to become students when interacting with individuals of other cultures. So when you walk into a community, you bring your area of expertise into that community, but the community also has their expertise as well. So it's an exchange, and always look at working in any community as an exchange versus I am here to tell you what you need to do. And so I would really like to encourage listening is a very important skill when working in a different community that you're not familiar with. And so if you have time, go and read up on cultural humility and you'll get to learn more about how to go about this. But it's something that has worked for me, and I still embody in the work that I do with refugees that are coming from very diverse backgrounds. And so it's being a forever student and bringing humility to your work.
Excellent, thank you for that. Other responses?
Yeah, I can build on that. I think that's a really great point. I think moving towards cultural humility and away from sensitivity is really important. And that, as Dora said, it's a lifelong sort of work and lifelong lesson to really engage in that work. And really, you just have to get used to being uncomfortable, being confronted with things that may not be always positive about your experience. I see this work as being, a combination of being reflective and also being action-oriented, right? So you have to have lifelong commitment to being self-reflexive, self-evaluative about, where your privilege lies, whether it's based on your race, gender, sexuality, socioeconomic status, and then to identify that and to be action-oriented. I think inequity in public health as a sort of practice about moving towards equity is about finding imbalances of power, and then finding ways to fix those imbalances in your personal and professional life. And so I think the actions that have been sort of useful for me in my career, about reading more, seeking out stories of people and groups that have been marginalized, the power that I do have, sharing that power, elevating groups, opportunities to groups that have been marginalized, and developing partnerships. I think you'll probably hear this a lot today from all of the panels. Partnerships with community organizers, with groups that have been marginalized are so important in order to advocate for moving towards equity. So I think those are really the strategies that have been useful in my career, and I think if you read through sort of the literature, I think those are things that they recommend as well.
Thank you so much. Were you going to add something, Dr. Woods-Jaeger?
Yeah, and I largely echo what's already been said, and I'm a big proponent of cultural humility. And in terms of research and academia, I think we have a lot of work to do embracing that framework and really looking at different ways we can apply it. And so exactly what was shared about how can we be more self-reflective, particularly about the research questions we're asking, who's asking them, what methods are we using, who identified this as a research topic of importance, all these things really being critical about it, and asking ourselves who's missing and who do we need to include from the beginning. And then I really think this issue of power is huge in research, and we often don't talk about it as explicitly, but in my work, doing community engaged work, there's so much in terms of the power imbalances, just in terms of who has the resources. So where is the budget going? Who's managing the budget? And who makes the decisions? Like who is really at the table, able to make those decisions about what grants we're going to go for, what manuscripts we're going to write, what presentations. So I think it takes a lot of time, and it is, as someone mentioned, you have to get comfortable being uncomfortable, because there's a lot of tension when you do that, because you're really thinking more about these issues that are institutional often, and that you're going to have to really be engaged for the long haul to address. But the benefits, I think, are tremendous in terms of when we're really explicit about it and focused on it, we can have much more, in my opinion, effective and relevant approaches that are sustainable in communities. So it's not just going to be a one-time research study and then we're done. That we're really building it from the beginning in a way to last. So I'm a huge proponent of cultural humility. I want to say that I know that students have really asked for that to be more infused in our curriculum, and I'm excited that we're doing that, because I think that's a really critical piece to be getting early on in your professional development.
Thank you so much, Dr. Woods-Jaeger. Dr. Sullivan, were you going to add something?
Yeah, I just want to reflect. I was so glad to hear Doris start out talking about cultural humility, and Matthew to sort of further that to power dynamics, and Dr. Woods-Jaeger to further that to research. So the one thing that I would like to add is that different aspects of culture, race, identity are intersectional, and so recognizing that, I would just amend this to say in building research teams that there's a need for this intersection of cultural and professional humility. So building teams that aren't too hierarchical, and explicitly talking to teams and acknowledging that the best answer to our questions often doesn't come from the oldest person or the person with the most degrees or the person that's highest in that structure. And I think that when the question is sort of how do we prepare ourselves to be effective and culturally sensitive. So I think this is a cultural issue around our teams that are delivering programs or research. And it takes active steps to communicate those messages and to create spaces where people can identify those different intersectional identities. Because often something might be about an understanding that comes from our racial diversity, but it also might be about an intersection between our sexual identity and our racial or ethnic identity. And so I think this is important in both realms, and I would just sort of pull that together and saying, I think these are challenges to those of us who have some, who need to acknowledge some privilege in the structures and in controlling, as Dr. Woods-Jaeger says, the money, the publications, and how do we make those group processes and groups that are not overly hierarchical.
Thanks so much to you all. The next question is from Mimi Nguyen. And she asked a question that beautifully builds off of this previous question. And her question is, could you talk about how your own race and class identity informed how you choose to practice anti-racist public health work? How can you overcome challenges faced in the field? I acknowledge this is a difficult one, and it builds off of some of the comments that Dr. Woods-Jaeger previously made around humility and vulnerability and comfort with being uncomfortable.
Yeah, I can try to answer that question. I think as a Black man, I think this work has been truly beneficial, I think, for those, who I'm seeking to help, right? So, other Black people, but it's also deeply personal, right? It's, I'm thinking about my own family. I'm thinking about, my father, my best friends, my uncle, people who have touched the system in different ways and been impacted by the system in different ways, whether it's through prison or whether it's through, not having the access to care that they deserved, and resulting to, early death and or early sickness or things like that. So I think my framework in this is, I'm trying to save not only the life of, the general population and improve outcomes there, but, I'm thinking about if I decide to have a son, have a daughter, moving forward, I want to make a system or create a system that also improves their lives and improves their chances at living a healthy and long and fulfilled life. So I think the work is deeply personal, and it definitely channels the way that I approach the work, which is to say that I think it's easy to look at health inequity as a large system, as a thing that's impacting groups of people, but it's impacting individual people ultimately, right? These are individual people who are, not living as long as they could if they were, benefactors of a system that works for them. Or, it's families who can't get access to medications they need or can't get access to healthy neighborhoods or healthy parks, and things that are going to be health protective factors for them. So I think for me, it's really about, acknowledging the large system level factors and the large groups of people, but also realizing that these are our friends. These are students that you're going to be going to classes with, right? People are impacted by this, and really, really taking the time to think through at an individual level, and really humanizing the subject.
Excellent comments. Thanks very much. Dr. Woods-Jager, were you going to add something?
Yeah, I would just echo that this is deeply personal work, and as a Black woman and a mother of kids in public school and my work in schools, I definitely am thinking about my family, my community, my kids a lot when I'm doing some of this work, and it's motivating. And it also, I think, as a Black woman, I'm keenly aware of racism, my own experiences, the experiences of colleagues, communities I work with, and so that always puts it on the table for me, and so has informed my research agenda in that way, and really needing to center that, in terms of the work that I'm doing. And I'm also really keenly aware of the strengths in the community. So I think with health disparities, health inequities, there's often a deficit framing, just because we're documenting the disparities, right, and the problems. And so for me, I feel like by being a part of the community, I see the strengths I have, all through, the way I was raised and how I was brought up, and the way that I've navigated really challenging systems. So that has really given me a lens of how much opportunity and promise there is with partnering with the community, and how hard and painful it can be too, because you win some, you lose some, and that's a really painful process at times, but being able to be in it for the long haul because there is that personal motivation as well as that awareness and experience of what power is in community.
Thanks so much to you both. The next question from the audience is, what is an example of a policy currently needed that would address racism in public health?
I'll take a stab at that, and I think just across, I would say, decades of work that I've engaged in trying to understand health inequities, particularly around race and sexual and gender minority, that I think that a policy change that is needed is the expansion of Medicaid, particularly in southern states. And so the question is about racism in public health, but I want to sort of broaden this out to say that in a variety of sort of disease-specific or health condition-specific research, health insurance comes up again and again, and is a component of structural racism as we think about that as something that shapes health. And I think until there's a level playing field or a more level playing field with respect to access to healthcare, that having that level playing field would actually reshape how we can do better in public health and provide us more of a platform from which to think about ways to minimize health inequities. And I would just note that the range of health conditions that lack of health insurance impacts both along lines of inequity by for socioeconomic, for income, for race, for ethnicity is very broad. So I think that might be a point that we should rally around, particularly with respect to inequities.
Thanks so much, Dr. Sullivan. Any other comments on that?
I have. I recognize that there are funding disparities when it comes to funding work that is, culturally specific. There is the approach of a template approach that needs to be looked into further, and for funding to be more culturally tailored to programs that are culturally tailored. So programs that are working in unique communities are underfunded, and with that comes the lack of resources to do what needs to be done to tackle the health disparities that exist. And so that's one thing in working in the nonprofit world that we come across often, is the funding disparities. That's one thing that I can think of right now.
Thank you. Mm-hmm. Another question from the audience. This is from Kyler Moore. Is there a problem in a lack of diversity when it comes to clinical trials and research? I see you head nodding. Dr. Sullivan, would you like to take this?
Yeah, it makes me think one of the blessings and curses of having been being further along in my career is that I was working on this very same problem with respect to participation in HIV vaccine trials around 2000. And unfortunately, I think the same issues and the same underlying issues still impact our research today. And I'll just sort of bring this forward to a very current issue, which is COVID-related research, where CDC recently did a sort of household survey to look at COVID prevalence in the Atlanta area, and had quite low participation from African Americans and other Black households. And then subsequently in the AJC, there was more detail about the reactions of families that were approached, by CDC folks knocking on the door, and the sad legacy of Tuskegee and mistrust in research. And so, and then I'll just carry that forward to say that in a national study that we're conducting at Emory of COVID prevalence and antibodies, that we're encountering the same problem. And so I think that, again, I'll go back to cultural humility, which is that as much as we can do up front by engaging communities and asking about what the concerns are in the research, learning how to proactively address concerns that might arise. But then when enrollment and participation isn't equitable, going back again with humility. And so our next phase is to start to engage people who we invited to participate in this research and who chose not to, and to ask what we could have done differently. So I would just say it's a problem that's existed for decades. It's a problem that in some ways has been of the making of the biomedical research community. We as a community contributed to this by what happened in Tuskegee, and we have a responsibility to be proactive. And I think it's will persist for a long time to come, but some of the steps are starting as early as possible, and then with humility going back and asking how we can do better. And that really it's like weeding the garden. And it has to be done for each and every study to understand how we can do better.
Thanks very much, Dr. Sullivan. Dr. Woods-Jager.
Yeah, I just want to build on that, and I echo that. Yeah, I think taking that approach of cultural humility and taking the time to build trust. So I think people talk a lot about mistrust in the community, and really we should be talking about mistreatment. And researchers too, and current researchers, I mean, going into the community, doing these surveys, and then the community doesn't see anything in return. And so my partners, as we start to work together, they're very aware of that. And that is our first discussion. And how can we build an infrastructure to prevent that? Because as a researcher, I have to do that critical self-reflection and realize the pull is to do that, because you get pubs out faster, you get grants out faster. And so I have to really be able to be humble and called out by my partners if we're starting to move in that direction. And when you do that, I want to say, so I think this is a persistent problem, but there are definitely, we can fix it. It will take time. We just recently, with that partnership I described that we've been working, the past 5 years, when we rolled out our COVID survey with urban Black youth, and that are very busy doing other things, we were able to get 100 participants in 2 weeks because there was that trust, there was that relationship, and they knew the data was going to come to them first. And that is where the data is going first. And so I think, we have to think about the way that we do things, that there's a lot of opportunity, and cultural humility. Again, I love that that's become a theme of this, I think is a real framework for us to embrace to do that type of work.
Thank you so much. I don't know if you had a comment, Mr. McCurdy. I was trying to watch to see. Please, Ms. McCongo.
Yes,
I don't have a comment. Oh, sorry. Go ahead.
So, I would like to add to what Brianna just mentioned. Trust is a huge factor when it comes to communities of color. The community-based organizations are integral in getting access to communities, and they are frequently left out of the equation when researchers come into a community and want to, do some research. So engaging community-based organizations who really are the DNA of the community, have inroads into the community, are the trusted voices of the community, just bringing them to the table at the very beginning, not at the end of, after the research has been designed. And we've seen that happen at Amani Women's Center. We've successfully worked with the CDC and other partners by engaging the community ambassadors who are part of our team, who are leaders, trusted leaders of the communities. And I have to say here that leaders in the communities don't look like your typical leaders, so the community leaders could be the most elderly person in the community whom the community goes to for advice. And so there's a lot of assets already in the community that we could tap into. And so I would encourage that relationship building and collaborative approach, like Brianna had mentioned.
Thanks so very much. Mr. McCurdy.
I don't have anything to add. I would echo, really working with community organizations as early as possible in the research development process. I think familiarize yourself with, who's doing what in your health area expertise or desired expertise, and really learn even from the creation of your problem statement. What are the issues that really need to be solved, and how can we link with community organizations to make sure that the research is done well and that the approach that we may have for our intervention is one that will be sustainable and relevant to the community that you're looking to impact.
Thanks so very much. These students at Rollins are hungry to learn. They want to learn more. They want to read. The last question is this: were there any books or resources that were particularly helpful for you to understand the deep history of medical disparities? I'll ask each of the four panelists to share the book that was most influential for you before we conclude the panel.
So many books.
Where do you start, right?
So I can think of, I'll name three that I really thought approach not necessarily medical disparities, but really gave a historical perspective on how race and racism impacted general outcomes for Black people. So Medical Apartheid is one book that I really recommend to a lot of people. Color of Law really gets into how segregation has an impact on outcomes. And then Stamped from the Beginning is a book that really just outlines the entire history of race and racism in this country in particular. And those three books, I think, will really equip you with a lot of knowledge to have nuanced conversations about race and racism as it impacts health.
Thank you. Dr. Sullivan.
I'll take a slight spin on that, which is to say I'm almost done with the book How to Be an Anti-Racist by Ibram Kendi. And I think although this doesn't directly address the question about the history of racism, I think it's forward-looking and reframes just how we like that sort of non-loss framework that Dr. Woods-Jaeger and I think Mr. McCurdy mentioned, which is how do we pivot off this and how do we challenge the ways we're thinking about equity. And I think about this, yes, with respect to services, but also with respect to our educational systems and our research structures. And I'll say it has been, it's sort of helped me challenge and rethink my own response.
Thank you. Dr. Woods-Jaeger.
Yeah, so I'll just name a couple of books, but then I want to say that I learned the most really from community mentors. And so I recommend that everybody get a community mentor who is willing and who is mutually beneficial, because they are very busy. So if they're going to mentor you, there needs to be a mutually beneficial relationship there. But that's where I've definitely learned the most. Community organizers in particular, I mean, that is such a sophisticated and rigorous field that I don't think we've always recognized. But in terms of books, The Teaching Community by Bell Hooks is one that just really influenced me. So I think there's so many great books in terms of the history and just opening ourselves up to all the data, right, and the facts. And then I've also just really resonated with books that help us think about kind of frameworks and ways that we can tackle some of these issues. So that's one that I highly recommend.
Thank you. And last but not least, Ms. Mukongo.
So my personal experience has been learning from community, and this has been through volunteering in different places. I was fortunate enough to volunteer at the DeKalb County Board of Health, where all refugees come through to get medical screening when they are resettled in Georgia. And that opened my world to the different communities that exist right here in our backyard. And spending time there volunteering, listening, learning, engaging, building relationships, that is more profound than any book that I have ever read. But there's a particular book called Creating a World Without Poverty by Muhammad Yunus. And that has also, that has influenced the work that I do and in understanding how eradicating poverty can really help and change, and tackle the disparities that we're all talking about today. And so that has been a powerful read for me that I go back to over and over again.
Thank you so very much. My deepest gratitude for this phenomenal panel. Thank you so much for your time today. And thank you to the students who were brave enough, kind enough, willing to submit questions that really drove this panel. At this point, I'll turn the session back over to Joanna Imposta-Williams and hope that each of you have a wonderful day. Stay well.
Thank you, Dr. Kimberly Jacob Ariola, for moderating a stellar faculty and alumni panel. Panelists, we appreciate all of the work that you've done for not only Rollins, but also the community. That was a very engaging discussion on the intersections of racism and COVID-19 here in Atlanta. So we're going to wrap up our program. I want to thank each of you for tuning in to our virtual CDC day. I also want to give a couple of special shout outs. Ruin Moodley and Apurva Kamujasula, as well as Norman Eubanks, who are assisting me remotely from the Rollins School of Public Health, as always, to wrap up our orientation program, as well as Chris and Eric, our fabulous AV and IT folks here at CDC. And again, a very special thank you to Captain Eric Tevsner and the Epidemiological Workforce Branch, the NCAMS team, as well as you all for making this virtual event possible. Thank you so much and have a great day. Take care.